Now we're going to have a virtual presentation. We have Dr. Mairead McNamara, who's a medical oncologist at the University of Manchester and the Christie.
Good evening. I'm Mairead McNamara. I'm a medical oncologist based at the University of Manchester and the Christie NHS Foundation Trust. And I would like to thank the organising committee for giving me the opportunity to speak today on the microbiome and the ABC-12 study. I'm sorry I couldn't be there in person. So these are my disclosures. So this is an overview of my talk today. I will divide it into 3 different sections. The first section, I will go through some definitions related to the microbiome and diversity. Then the second section, I will talk about guidelines that are recognised internationally for the management of patients with biliary tract cancer. And this will include a brief mention of the TOPAZ-1 clinical trial. I will then move on in the third section to talk about the ABC-12 study, and then I will summarise. So what is the microbiota? So the microbiota are living microorganisms in a defined environment. And the different environments that may exist would be the oral and gut microbiota, for example. So the different microorganisms may be bacteria, viruses, or fungi. And if you just look at the figure on the right-hand side, this gives an example of the different environments and the different microbiota that may be associated with those environments. So here in the figure, you have 5 different environments: the respiratory, oral, gut, skin, and vagina. And there are different bacteria associated with all these different environments, and they live there and coexist with the host. So the microbiome then, this is a collection of genomes from all the microorganisms in the environment. And when you're thinking about microbial communities, they live in symbiosis with the host, regulating immune function. So they are required for normal functioning of the human being. So the gut microbiota, as you can see here, highlighted by the red arrow, they are considered the most significant in maintaining health. And they are involved in fermentation of food, protection against pathogens, stimulating the immune response, and in vitamin production. So just some examples of the bacteria are listed there and can be actinobacteria, Bacteroides, etc. And there are different bacteria in the different environments, as I have mentioned previously. So gut microbiota, they may vary due to age and environmental factors. So there are different environmental factors that I will mention briefly later. And one of those may be medication usage, for example, such as antibiotics or steroids. The bacterial diversity then increases between childhood and adulthood, and then decreases in people who are greater than 70 years of age. What is microbial diversity? So there are diverse communities of resident bacteria, and they're protective from disease-causing microorganisms. Dysbiosis then means an imbalance in this microbiota. So microbiota community balance can be affected by external changes, leading to dysregulation of bodily functions and diseases. So the different types of diseases that can result from these external changes and alteration of the microbiota would be, for example, heart disease, inflammatory bowel disease, liver disease, such as cirrhosis or hepatitis, and both of those could potentially be risk factors for the development of bile duct cancer, biliary tract cancer, or primary liver cancer, hepatocellular carcinoma. Other diseases that can be caused by dysregulation of microbiota would be chronic kidney disease, brain disorders, diabetes, respiratory disease, and other cancers such as lung cancer, colorectal, pancreatic cancer, and mouth cancer. So what happens then if there's a disbalance or an imbalance of microbiota is dysbiosis can generate an immunosuppressive environment. So I mentioned that there can be different environmental effects on the microbiota, and they can be due to the microenvironment or the macroenvironment, with microenvironment being factors such as smoking, alcohol, and diet, and then the macroenvironment being what's happening in the broader surroundings of the person or patient, such as socioeconomic environment, toxicological or chemical environment, and this can include medications, which all can have an impact on the microbiome. So I'm now going to move on to the second section of this talk. So in the first section, I have just gone through some of the definitions, the microbiota, the microbiome, and dysbiosis or alteration in the microbiota. This second section now, I'm just going to talk about what is standard of care in the treatment of patients with biliary tract cancer. So globally, there are guidelines which are accepted, and these help to guide physicians as to the correct management pathway for patients with bile duct cancer. These are the ESMO guidelines, which stand for European Society for Medical Oncology. And the top BTC stands for, in the purple box, is biliary tract cancer. And if you look then at the blue arrow, this indicates patients with advanced disease. So these are patients where surgery is not a possibility. And if you look at the red arrow, for patients with advanced disease, the first line standard of care that is now recommended is a combination of chemotherapy with immunotherapy. So that's cisplatin gemcitabine with durvalumab or cisplatin gemcitabine with pembrolizumab. So what is the evidence that supports this combination to be used in first line for patients with advanced disease? So the TOPAZ-1 clinical trial was first published in 2022. So this trial reported that the combination of cisplatin gemcitabine durvalumab improved survival in patients over the combination of chemotherapy with cisplatin gemcitabine alone. This figure is called a Kaplan-Meier curve. On the x-axis, you have time from randomization in months. So that means the time from a patient starting on treatment. So that goes from 0 to 36, and these represent months. On the y-axis, you have overall survival, with up at the top of the line being 100%, so 100% of patients start on treatment, and then as patients come off trial, then there's a drop in the curves. The red line represents those patients that received the chemotherapy with immunotherapy combination. The blue line represents those patients who had the chemotherapy alone. And you can see that the median overall survival for patients who had the combination with chemotherapy and immunotherapy was better than for those who received chemotherapy alone. So median survival was 12.9 months versus 11.3 months. ORR represents the objective response rate. So if you see in the red, the response rate for the patients who had chemotherapy with immunotherapy was better than for those who had chemotherapy alone, 26.7% versus 18.7%. So approximately a quarter of patients had response to treatment, had response within their tumours to treatment. So what I mean by response and what is meant by response is a combination of the percentages of patients who either have a complete response or partial response. Complete response means disappearance of all lesions when the patients have imaging. A partial response means that there's a reduction of greater than 30% in the overall diameter of the lesions. So what is interesting with the TOPAZ trial and with the other trial, the Keynote 966 trial, which has established cisplatin gemcitabine pembrolizumab as another standard of care option, is that at 2 years, you see the yellow arrow here marks the 24-month period, and at that point, twice as many patients were alive who received the chemotherapy with immunotherapy. So in responders, the patients who either had a partial response or complete response, 40.6% of patients were alive at 2 years versus 20.5% alive at 2 years who received chemotherapy alone. So what we don't know is how to predict these patients who will do better from the addition of immunotherapy to chemotherapy. And that is why the ABC-12 clinical trial was set up. So just to keep in mind, in other disease sites, particularly renal cancer, lung cancer, and melanoma, it has been shown that patients with a greater diversity of their microbiota did better on immunotherapy. So that's more and different types of bacteria within their system that they actually did better on immunotherapy. So in biliary tract cancer, this has not been looked at in a prospective fashion. So that means in a clinical trial which recruits patients looking specifically at the microbiome. So the ABC-12 clinical trial is currently recruiting patients in the UK who have a diagnosis of bile duct cancer and gallbladder cancer. 70 patients are to be recruited in total, with approximately 2/3 already recruited. Patients will receive cisplatin gemcitabine with durvalumab, and they will provide saliva samples and stool samples at baseline before they start treatment, and again at 18 weeks or when the treatment stops working, if that is earlier than 18 weeks. And the primary objective of this trial is to determine the difference in the baseline alpha diversity. So that means the different, it's a measure of the microbiome diversity applicable to a single sample. And we'll be looking at the difference in bacterial diversity between patients who have response on their imaging versus non-response. So at the moment, there are 9 sites currently recruiting in the UK, and these are highlighted in this figure. These include Manchester, Liverpool, Birmingham, Wales, Nottingham, Oxford, Cambridge, and 2 sites in London, Imperial College and Royal Free. And what we're hoping in this trial is that we potentially may be able to identify particular bacteria that may be associated with better response to immunotherapy. And if that is the case, then there may be the potential to develop therapeutics in the future based on this. So what is the therapeutic potential of causing alterations in the microbiota? So you can modify the gut microbiota in different ways, as illustrated in this figure. On the top, you have diet, prebiotics. Then you have probiotics as an example of modification of the gut microbiota, fecal microbiota transplantation, phage therapy, which is essentially viral therapy, engineered bacteria, or live biotherapeutic products. So, for example, in terms of diet, the best prebiotic foods that have been reported would be things like apples, garlic, chicory root, unripe bananas. And the advice is to avoid low fiber diet and processed foods, as a high fiber diet serves as a substrate for certain bacteria, which break them down to form short chain fatty acids, which have then anti-inflammatory properties. Examples of probiotics can be seen here on the right hand side, and they have been listed 1 to 11. I'm just going to mention a few of them. The best in terms of probiotics and modification of the gut microbiota is mentioned as sauerkraut. 3rd on the list was pickles. 5th on the list was yogurt. 6th was buttermilk. And then cottage cheese and sourdough bread at 11. Other examples of altering or modifying the gut microbiota are fecal microbiota transplantation, where you introduce a solution of fecal matter from the donor into the intestinal tract of the recipient, and changes in the microbial composition, which changes the microbial composition directly. And this has been used in patients who have resistant Clostridium difficile infection. So in summary, the gut microbiota is involved in maintenance of health. Microbiota balance can be affected by external changes such as smoking, alcohol and diet, and medications as well, and other environmental changes. Microbial diversity is protective from disease-causing organisms. Then moving on to biliary tract cancer, We know that immunotherapy with chemotherapy is now standard first-line treatment for advanced biliary tract cancer, but not all patients respond equally. So how can we identify the patients that may respond better? Is there an impact of the microbiome? And ABC-12 trial is exploring this and exploring the impact of the microbiome on the response to immunotherapy chemotherapy combination in patients with advanced biliary tract cancer. And if there are particular microbiota associated with response, then there is the potential in the future to alter microbiota and potentially use this as a therapeutic option. Thank you very much for listening, and I hope that you enjoy the rest of the conference.